Good afternoon. I'm In-Chang Hwang, working at Seoul National University Bundang Hospital. Thank you for inviting me to this session, and it's a pleasure to talk about cardiac sarcoidosis in this session. And I apologize that I couldn't participate in the offline meeting. Sarcoidosis was first reported in 1899 based on the histologic findings of a patient who demonstrated multiple benign skin nodules. It is a multisystemic granulomatous disease, and the immunologic response is the main etiology. Histologic hallmark is the non-caseating granuloma, which is a complex of activated macrophages, amyloid A aggregation, surrounded by lymphocytes and fibroblasts. The prevalence is estimated about 5 to 60 per 100,000 persons, predominates in women and middle-aged persons. This disease can involve various organs, and the cardiac involvement is reported only in 2% to 5%. However, according to an autopsy study of patients with sarcoidosis, the cardiac involvement was identified in at least 25% of patients with sarcoidosis. So it means that subclinical cardiac involvement is common. When you focus on the patient with cardiac sarcoidosis, most of them have minimal extracardiac disease, and about 30% have isolated cardiac sarcoidosis. The symptoms and signs of sarcoidosis depend on the location, extent, and activity of the disease. Involvement of septum often lead to AV block, and reentry circuit in LV myocardium can make the ventricular arrhythmias, and extensive myocardial involvement can lead to heart failure. This patient shows typical signs of cardiac sarcoidosis. He presented with dyspnea and dizziness, and we found complete AV block. On echocardiogram, we observed multiple non-coronary territory regional wall motion abnormalities at basal anterior septum, basal inferior septum, basal inferior, and also alveoli free wall. The confirmative diagnosis of cardiac sarcoidosis can be made by endomyocardial biopsy, but we all know that its diagnostic yield very low. Recently, the electroanatomic map guidance biopsy have shown promising results, but it requires intense cooperation with EP specialists. Instead, in patients with typical features of cardiac sarcoidosis, the detection of non-caseating granuloma at other extracardiac organs, such as hilar lymph nodes, can provide accurate diagnosis. Because the endomyocardial biopsy have very low sensitivity, we need to think about the clinical signs of organ involvement. Patients with cardiac sarcoidosis can have abnormal ECG findings, such as AV block and ventricular arrhythmias. And we also know that there are typical signs of echocardiogram. In clinical practice, most of the cases of cardiac sarcoidosis start with echocardiogram. Many patients with cardiac sarcoidosis have abnormal echo findings, such as regional wall motion abnormalities of non-coronary distribution or thinning of basal anterior septum. When you see these findings, the cardiac sarcoidosis should be considered as one of the possible diagnoses. But we also know that it's not specific for cardiac sarcoidosis. So the biopsy has very low sensitivity. Biomarkers such as angiotensin converting enzyme level is usually not helpful, and the clinical signs are not specific for sarcoidosis. So it is important to use the advanced cardiac imaging studies such as nuclear imaging or cardiac MR for the diagnosis of sarcoidosis. As shown in these typical patients, the LGE pattern on cardiac MR is often patch and multifocal, spares the endocardial border, and is commonly observed at basal segments. But these LG patterns are not specific for sarcoidosis, and ironically, the non-specific pattern of LGE is often regarded as the typical finding of cardiac sarcoidosis. More importantly, even in patients with cardiac sarcoidosis, the presence of LGE indicates the myocardial fibrosis, but not the disease activity. To assess the disease activity or the burden of myocardial inflammation, myocardial PET scan provide valuable information. The cardiomyocytes utilize both glucose and fatty acid for energy source. However, inflammatory cells utilize only glucose, but not fatty acid. So this difference makes it possible to detect myocardial inflammation using the PET scan. The activated pro-inflammatory macrophages in the inflamed myocardium have higher metabolic rate, and it uptakes more FDG. So it makes it possible to assess the disease activity using the PET scan. And because the sarcoidosis makes granuloma at multiple sites, the typical feature of myocardial PET scan is focal or focal on diffuse pattern. Cardiac MR provides high-resolution images, and it shows the myocardial fibrosis but not disease activity. And instead, the PET scan shows the disease activity, but its resolution is not good enough. So some institutions tried the simultaneous PET scan and cardiac MR, which shows these hybrid images. In our institution, we do not perform the PET scan and cardiac MR simultaneously, but our nuclear imaging specialists provide the fusion images like this. They fuse the cardiac MR and PET scan on the same plane of myocardium. These hybrid images shows the myocardium with active inflammation, and it can differentiate the advanced fibrotic portion from the active inflammation. For diagnosis of cardiac sarcoidosis with PET scan, specialized protocols are required because the normal myocardium uptakes glucose. The increased FDG uptake in myocardium is actually normal finding in usual PET scan. It can be easily found in patients with cancer. So in order to differentiate the inflamed myocardium from the normal one, we have to suppress the glucose uptake in normal myocardium. It is possible because myocardium utilizes both glucose and free fatty acid as its energy source. When the physiologic glucose uptake in normal myocardium is suppressed, then the inflamed myocardium can be detected because the activated macrophages uptake the FDGs in the inflamed myocardium. The essential preparations for suppression of physiologic glucose uptake in normal myocardium include the high-fat, low-carbohydrate diet, extended fasting, and intravenous heparin injection. Several societies suggested the similar protocols, which include low-carbohydrate, high-fat diet, extended fasting, and injection of heparin before the injection of FDG. In our institution, we developed a special low-carbohydrate, high-fat diet with cooperation with the nutritional support team of our hospital. This diet consisted of less than 5 grams of carbohydrate per meal, and it contains more than 35 grams of fat per each meal. So we give this diet for lunch and dinner on the day before the PET scan. Then after dinner, the patient undergoes extended 18 hours of fasting. And the next day, before the FDG injection, we give intravenous heparin. And also we measure the serum level of free fatty acid. It is to ensure the appropriate suppression of glucose uptake in normal myocardium. It can be achieved when the free fatty acid level is higher than 1000 microequivalent per liter. Using the typical features of ECG, echo, and nuclear imaging, major societies use the diagnostic criteria. In the 2014 Heart Rhythm Society guidelines, the histologic diagnosis is essential for the decision, and clinical features can make a possible diagnosis or probable diagnosis. However, in the 2016 Japanese guidelines, the clinical diagnosis can be made in patients even without myocardial biopsy. It can rely on the typical findings of cardiac sarcoidosis or non-invasive testings. Other guidelines also emphasized the clinical diagnosis based on clinical features of cardiac sarcoidosis without requiring myocardial biopsy. Recently, Professor Sondaewon also suggested a modification to the previous diagnostic criteria in which the positive myocardial biopsy finding is not a mandatory, and the diagnosis can be made on typical findings on echo, cardiac MR, and PET scan. After the diagnosis, then the treatment should be prepared. The mainstay of treatment is, of course, the steroid. Usually we give prednisolone at a dose of 0.5 milligram per kg per day for 2 or 3 months. After this high-dose steroid, then repeat PET scan is recommended, and if there is no abnormal uptake of PET scan, then we can reduce the steroid dose. It can slowly tapered and then maintained at a low dose up to 9 months. So in total, the patient should receive steroid for 12 months. Repeat PET scan is important because it reveals the treatment response and any kind of recurrence on the images. So even after the stopping of steroid, then another repeat PET scan is recommended. When the first-line steroid therapy does not work, then we have to prepare the second-line treatment. It includes methotrexate with folate supplement or azathioprine or other immunosuppressants. Another important treatment plan is the prevention of sudden cardiac death. The ICD needs to be considered in patients with cardiac sarcoidosis when the patient reveals sustained VT or persistent LV dysfunction, or when the patient has indications for permanent pacemaker implantation. So I'll show you another case who shows the typical clinical course of sarcoidosis. She presented with pulmonary sarcoidosis, and we found high degree LV block. And the echocardiography showed atypical regional wall motion abnormalities, and the coronary arteries were normal. The cardiac MR and PET scan showed myocardial fibrosis at the exact point where the regional wall motion abnormalities were detected. And in that segments, we also found increased FDG uptake, which means the active myocardial inflammation. After the diagnosis, the patient received high-dose steroid for 3 months and also had ICD implantation based on the indication of permanent pacemaker. After high-dose steroid therapy, the follow PET scan showed decreased myocardial FDG uptake. Then the steroid was tapered off and the PET scan was repeated again. But at this time, we found increased FDG uptake at hilar lymph nodes, which means the recurrence of sarcoidosis. So the high-dose steroid therapy was reinitiated, and after another 3 months of high-dose steroid, the PET scan showed significant FDG uptake in myocardium. So it means the treatment failure with steroid. So we had to give the methotrexate as a second-line treatment, and it worked. So now the patient is on a stable condition. This is the final slide for summary. The cardiac sarcoidosis is a very unique disease and requires many testings for diagnosis. However, recently, the paradigm is shifting to not requiring the endomyocardial biopsy. And typical clinical features on non-invasive tests, especially the myocardial PET scan with specialized protocol, can make the clinical diagnosis. The first-line treatment is a steroid, and second line is usually methotrexate. The treatment response can be monitored with PET scan, and the indications for ICD should be considered during the treatment. So that's all of my presentation, and thank you for your attention.